My name is Mitch Gluck. I'm the Assistant Administrator here at San Diego County Psychiatric Hospital. We're a freestanding psychiatric hospital, and the mission of our hospital is to serve those who are unfunded, who have no resources. We're considered to be the safety net for the County of San Diego for the acute psychiatric ill individual or for the chronically mentally ill person who has an acute episode of their disorder. I would say probably somewhere around 40%, 50% of the population that comes into the hospital. It may even be higher than that. Some of the barriers that they have is tied to the fact that they don't have adequate resources. That could be everything from financial resources to social and familial supports, medical care, transportation, housing. Housing is a huge barrier for the chronically mentally ill who are homeless. In San Diego, it's estimated that about 20% of the homeless have serious mental illness, and trying to get them engaged in services prior to a crisis occurring, prior to the onset of an acute phase of their illness is very difficult for so many reasons. But the lack of resources, lack of the ability to outreach and get them connected and to stabilize them, particularly in terms of housing, is a huge barrier to helping them with their disorder and being able to progress in life. Historically, the resources for the homeless have been more concentrated in the downtown area and central San Diego. I would imagine that it's much more difficult for homeless people to access services because like the homeless being concentrated in downtown and central San Diego is because there are so many more of the services that are centralized there too. With services more spread out in North County, I'm sure it's much more difficult for those who are homeless to be able to access anything that they might need, or vice versa, for the providers to be able to access them. Substance abuse is rampant. About 75% of the individuals that we see that come into our emergency room who are chronically mentally ill are also actively abusing substances. Preponderance of individuals who are chronically mentally ill will use substances in large part for their own medication purposes. Some will use it recreationally, some will use it for both. We see a lot of individuals who try to deal with their symptoms, the acute phases of their illness, the fears, the discomforts, the anxieties that are associated with a lot of their psychiatric symptoms by self-medication, and that's through substance abuse. It provides some relief, or at least it's perceived as some relief. It compounds, obviously, the illness phase that's going on. It makes it much more difficult to even treat the individual. Those who are not homeless have many more resources, if you will, in their arsenal to deal with their disease and with the disorder. And so they may be able to, for instance, get into treatment more frequently during the pre-morbid phase, just as symptoms are starting to appear, so that prevention of something much more acute can occur. They are receiving medical care for medical issues, non-psychiatric medical issues, and with the homeless, the medical care is often not existent. The lack of good nutrition, again, the lack of housing, all those factors can exacerbate the intensity of somebody entering a phase of an acute part of their disorder. It can not only exacerbate it, it can prolong it, it can trigger many more episodes. And so what you'll see frequently between those who have resources and those that don't is those that don't have resources will have more episodes in the course of a year, will tend to have longer recovery periods, will have many more readmissions, will have many more failures in terms of post-hospital care, because cost to an individual is the disease itself and the quality and safety of life that's lost as a result. The cost to the healthcare provider, somewhere in the neighborhood of $1,200 a day is the typical inpatient cost for serving somebody. So if it's a hospital such as ours, we're talking about taxpayer money, public monies that fund this care. Psychiatric care, particularly at the acute level, is extremely expensive. That doesn't even take into account the cost to the larger community, the cost to society, the lost productivity. Many individuals who have no other resources when they have a medical or a psychiatric emergency other than to go to the emergency room, the impact that has on hospitals. And that is one of the most costly levels of care, and yet that is typically the first form of medical care provided to those who have no resources, because when they don't get care until they're in a crisis, and when they're in a crisis they end up in an emergency room. Then you start going down the list of ancillary community-based services that are also involved in providing care to the chronically mentally ill / also homeless. We're talking about law enforcement, all the resources that law enforcement gives in terms of intervening with individuals in the community who are having an acute episode of care, making sure that those individuals end up going to the proper hospital or proper location for care. The correctional systems are becoming surrogate psychiatric hospitals because so many of these individuals are ending up in jail, which is not really the appropriate place, but there is no other resource at the time. They may have committed a crime, but the underlying causation may be a psychiatric illness. And so our jails are becoming overpopulated. Regardless of what direction you look at, there's an incredible human cost, there's a societal cost, there's a financial cost. It's kind of astounding when you take all of the costs and pull them all together and see how much of an impact it has. That Housing First operates on a philosophical basis that in order for a person to be able to succeed in the community and succeed in terms of dealing with their own illness, is that stable housing has to happen first. That's the essential. And that when individuals get into stable, not temporary housing, but stable, permanent housing, then they are able to take advantage of treatment programs, a whole array of biopsychosocial, community-based rehab. Whereas the housing that's based on a continuum of care is that people will not get into permanent stable housing until they've succeeded in treatment. That occurs first. And if an individual is to be able to demonstrate true success in the completion of treatment and other kinds of services that are associated with their illness, before they can get into permanent housing, that many people don't make it that far. They have to keep going back in kind of a cycle of treatment before they ever really reach a level of success, and many don't. Many will drop out, or there may be a variety of barriers, particularly when we're talking about the homeless. One of the principles behind the concept that stable housing first will engender more success, that if individuals have a home base, have a way of being able to take care of very basic needs. When we talk about succeeding in treatment, we're really talking about at the higher level of needs, because the basic needs aren't being addressed first. The basic needs of shelter, food, safety, those things are all missing for the homeless. There's a program, for instance, in Virginia where they've instituted a Housing First program. They've looked at comparative data between setting persons up into permanent housing first, and then moving forward with all the psychosocial programs, treatment programs, versus the providing those programs and services first. And then when the person is successful, has completed that array of services, then they get into permanent housing. Their results have shown that Housing First has a greater success rate. that if you can provide, again, stability for an individual, they are more likely to succeed in other forms of care that they're going to be receiving. The goal is to stabilize an individual. Stabilization means perhaps fewer episodes of acute illness. It means being able to get medical issues addressed a little bit more quickly so that they don't become life-threatening or debilitating. There are so many issues that homeless people have to contend with just for survival, whereas somebody who has stable housing doesn't have to worry about them and is able to move to what I would consider the higher levels of self-care. So you have a fiscal issue, you have a resource issue in terms of sufficient housing, sufficient wraparound services, community-based networked services. You have a psychological dynamic, a community-based psychological dynamic in terms of communities understanding that this is a need and embracing those kinds of services being provided in their environment as well. And so it involves not only the political arena and the social service arena of a community, but it involves, all the layers of society. When it calls upon all of those sectors of the community that I mentioned, it calls upon them to be able to work in harmony and to work smart. All the stakeholders who have to come together, recognize the problem, come to consensus on what the solutions are, what the strategies need to be, and then support it as it gets rolled out into the communities. Does it make more sense to pay for the most costly, the most acute level of care that is guaranteed to continue to repeat itself if nothing else is done? Or is it more cost effective to be able to help prevent that from happening? It would reduce the cost to society. These are individuals who need support, need a lot of intervention. It also helps resource allocation in terms of, with limited resources, whether they're fiscal or otherwise, how they will be used to serve other needs in the community. Being able to help individuals gain their own health, their own well-being, their own sense of dignity, to become productive individuals, self-sufficient, much more self-sufficient. It's basically humanity. It's the right thing to do from just a humanistic standpoint.